Morning everyone, and thank you for attending today. My name's Hazel Summers and I'm the Care and Health Improvement Advisor for the North West, working for the local government. I'm working very closely with my colleagues in North West ADASS, Matt and Leah, who are both on the call today. Just a little bit of housekeeping first. The session, just for you to know, the session's being recorded, so be aware of that. You are all muted, and that's for a reason, just because of the connections and all the rest of it. Please, can you use the chat for questions? We have a question and answer session at the end, and we'll pick them up all the way through the session, and we'll go back to them with our panel there. There's plenty of time for that. Please turn your videos off again. It quite often can cause a problem with the internet connection. So please turn your videos off unless you're speaking. I'd like to thank Ed Bradley from the ADASS team who's supporting us today. I'd also like to thank Leah Kelminiak actually for organising all of this and for all her hard work and putting it together. Just a little bit of context from me. When we went into the first wave of COVID, it became very clear very quickly that people from the BAME community were being disproportionately affected by that. And that was indeed the case for many of the care staff, also across all of the different types of services that we provide in adult social care. So on the back of that, and on the back of that concern, Matt Emerson and myself, Matt's the Programme Director at North West ADASS, went to speak to Abdul Razak, who was going to speak later today, and another Director of Public Health, to ask what we could do. What could we do to support and develop work to support care providers and carers about assessing the risk to their workforce. I have to say that on the back of that discussion with Abdul and the DPH, Matt and I were absolutely and utterly determined that we would go and try and make some difference in this piece of work. I think it's also worth saying that there's been a couple of reports. We know Public Health England sent out a report and published a report, I should say, who then set out some of the effects of COVID on the BAME population. And there's also been another report which has been published, I think today, it was certainly discussed on Radio 4 today, around from the ONS, which again talks about the disproportionate effects, where less probably about ethnicity and more to do with external factors, to do with housing and the kind of jobs people do, etc. Although clearly there are some other unknown factors in some of that. So I just want to go through who our speakers are today. So could we go on to the next slide, please, Ed? So this is the agenda. I'll just go through the agenda first. So there's a little bit of the All Wales COVID-19 Workforce Risk Assessment Tool. And I must just say that I'm really sorry about the fact that we can't have Sanjay here today. As you may well know, Wales has gone into a fire break, and his is a key role on, as he's the AD of safeguarding risk for the Welsh Government. He has a key operational role in that area. So, but what we have done is we have kept the video he sent us and an example of the tool that they've used because we found it very useful. We have somebody talking about their lived experience working as a carer, but also as a person who has both been on the receiving end of a BAME risk assessment and also having developed them herself for other staff. Then a little bit about what's happening in Manchester in the integrated health and care teams, and we have a colleague there from Manchester City Council who will talk about that. She works in reablement. Then we have Leah talking through the North West ADASS Risk Assessment Toolkit, and there's a question and answer session with our panel. And our panel is made up of Abdul Razak, Leah, Anushka, Valerie, and Safina as well. Safina works for CQC, so we'll have a panel, and it will be at that step that we will talk through all of the questions that you put in the chat. So we won't be answering questions on the back of each presentation. We will be taking them all at the end. So please start putting your questions in the chat as soon as you have one, and we will pick them up later. And then it's next steps and close. Next slide, please. Okay, we've got a quick poll now, and this is to answer a Zoom poll question that should appear on your screen, and I'm going to ask Leah to talk us through this.
Just taking myself off mute as well. Hopefully, I don't think there's too much to talk through. You should have had a Zoom poll pop up in front of your screen, and I can see colleagues are starting to answer those now. So fairly live, but we can see then that the majority of colleagues, certainly about 2/3, are reflecting that risk assessment, COVID-19 risk of Black, Asian and minority ethnic workforce, and I expect kind of broader vulnerable groups as well, is underway within their organisations. But interestingly, we can see a few colleagues responding that that isn't happening at the moment, or that there are plans to do so. And hopefully today's session will support those areas to kind of look at those plans and progress them, and for those that haven't already initiated, hopefully make a start on those. Also hoping that those colleagues who've already made a start on there will also be able to take something away from these sessions, because I think as we'll see throughout the presentations, that this does feel best approached as a kind of a regular and developing exercise, I think, undertaken.
Thank you, Leah. So interesting results there. Can we move to the next slide, please, Ed? And I think I'm really shocked that it worked. I have to say that I was nervous about the poll. So well done, Ed and Leah, for getting that to work. I'm absolutely delighted. Okay, what I'd like to do now is introduce Abdul Razak. I've mentioned him already. He's a public health consultant and at Lancashire County Council. And Abdul's going to talk us through the context of why we are doing this. Thank you. Has the polling gone off the screen? Ed?
The poll should have finished. Can everyone see the poll, or is it stopped?
No, it's definitely stopped, really, colleagues. Really,
yeah, it's stopped now.
Yeah, thank you, Hazel, really, and a very good morning, really, to everyone. Really, good to be with you this morning. So, the first thing I would like to actually say, really, is obviously to actually thank the team, really, on Northwest ADASS, really, for organising the first webinar, really, for the Northwest colleagues, and obviously this national webinar. Really, a huge amount of work has actually gone on, really, over the last few months to actually develop the BAME risk toolkit, as well as all the other work, really. And clearly, we're on a journey as part of service improvement to actually improve the lives of all of our communities. But in this aspect, really, our staff and our communities who clearly have an ethnic health kind of origin. So next slide, please, really. I want to start, really, by just giving a public health kind of view, really, around the pandemic outbreak around COVID and the current situation that we actually find ourselves in terms of the what is most often described as wave 2. The first wave of the pandemic clearly was quite a traumatic experience for us all in terms of a national lockdown, and clearly pandemics clearly follow in many ways, really, a pattern. They always don't fit a neat pattern, but this is the overall trajectory of what tends to happen within global pandemics, based on what we know of pandemics over the last 100 years and even longer. So there's usually a first wave, really, where there's immediate mortality, high deaths and morbidity, so basically disease burden. And we're seeing some of that, really, from the first wave. So you will have heard of long COVID, those unfortunate patients who clearly, even after 3 or 4 months, really have developed and continue to actually experience symptoms neurological, heart conditions, and so on and so forth. So clearly there's some emerging evidence around who those at-risk groups are, the elderly, those clearly young women in particular, and those with asthma seems to be the current evidence that we currently have, but it is an emerging kind of field. So after the first wave, really, clearly there's a tail, and clearly the NHS colleagues, as well as social care, in terms of the huge surge and demand experienced by everyone as part of that process, clearly resulted in a huge tailback, really, in terms of planned emergency operations actually being cancelled. And clearly the NHS is actually in phase 3 recovery to actually bring back some of those key essential services. Together with adult social care and the care sector, to actually get back to some level of normality and to actually then recover some of the services for our residents, especially the most vulnerable. Clearly, there's been a lot of work in preparation for this particular wave. So the second wave from this graph clearly continues to have impacts on resources, both COVID and non-COVID. And clearly, but however, what we have to say really is that our treatments overall really for COVID, if you're unfortunate to catch the virus really, and you are unfortunate to obviously experience severe symptoms, and if you end up in a hospital bed admitted, clearly your chances of survival are far greater in the second wave than they are in the first wave, because treatments and clearly therapies are a lot better, because we've learned far greater into the actual virus really. So that's really positive. However, having said that though, we're still seeing really from the early signs really that BAME communities are being admitted at a slightly higher rate. It's about 20% in terms of intensive care nationally, but it is an early picture. So clearly there's still some disproportionate effect on BAME communities overall. And clearly there are other impacts as well in terms of social impacts, the job losses and the economic kind of fallout as well as financial hardship. So clearly there's a long tail to this. So we're not out of the woods yet, and that's the main message that I want to obviously get across from this particular slide. Next slide, please. So there are, as I highlighted really, there are at least 6 dimensions of the impact, as I've actually mentioned really, and clearly this is just a slide really just highlighting that. So we'll move on really to the next slide. I think I've covered this. So wave 2, we're actually in the throes of wave 2 very much so, and I think the other thing to actually say really around wave 2 is that we are better prepared than ever in terms of our testing capacity, in terms of our test and trace, which is clearly we're doing local contact tracing as well, but clearly the overall upshot of this really is that the level of compliance within the general population to some of the standard measures really around face, hands and space is around 20% really. So overall population compliance really with those key measures is fairly low, and that clearly combined with social mixing as we've eased some of the national restrictions. However, we've clearly put those back in terms of some of the local alert levels, or the tier 2 and 3 in some parts of the northwest and Yorkshire as well. Clearly, the government is taking appropriate action to actually preserve and protect the lives of communities. So I think the ultimate issue here really is that clearly we can't rest on our laurels. There's just no room for complacency with this virus at all, and that's the key message really from wave 2 as we go into the winter. Thank you. Next slide, please. So these are the impacts. The impacts are actually vast across the life course, from pregnant women all the way to our elderly. You know, COVID affects every single individual, all communities, all faiths, all colours. It does not discriminate really. It's a virus really which clearly has had untold significance on us all really, and our lives clearly will be changed once we come out of COVID for a long time. Now, one of the key questions really is, will COVID ever go away? The current evidence clearly is from the Chief Scientific Officer, Patrick Vallance, that it's more than likely that this will become more flu-like in the coming years, and it will become an endemic disease which will reoccur and resurge on an annual basis once we actually get through this a few waves. So clearly COVID is a word really that we're going to have to get familiar with, and clearly we are obviously working to do our best to actually preserve and protect. And part of that challenge clearly is the introduction of the vaccines when they actually become available. And that is really relevant really for our health and social care sectors, because clearly they will be the first prioritised to actually receive and be offered the vaccine for uptake. And clearly the NHS is planning with our social care colleagues and the care sector in broader terms for that to happen. The vaccines are still in a phase 3 and 4 trial stage, so they've not been approved. However, the manufacturers, the pharma industry clearly have produced some vials of the vaccine, so they're ready to go once the regulatory authorities have actually approved the vaccine. So, in terms of timeline, really, we're probably looking at December at the earliest, which isn't far away, probably, but more than likely really into the new year, January onwards, really, in terms of the high risk priority groups that I've just mentioned, really, at the front line, who may be offered the vaccine to start off with, as well as the high risk populations. So clearly some positive progress, really, but the vaccine in itself will not totally eliminate the virus, and that's really important, really. So we're going to have to live with this for some time yet. Next slide, please. The work that we did really at the beginning, around May time, really, within Lancashire, within public health, working with our academic colleagues from up and down the country, was we did a rapid review, and this is available really on the University of Oxford Centre for Evidence-Based Medicine site. It's clearly a part of the overall evidence base at the particular time, and basically what it fundamentally actually says, and it hasn't changed as of some of the Leo was telling me really about the ONS and PHE report. And the Commission and the Equalities Minister, who I spoke to around July time. Basically, what we found really in terms of our evidence review was that the causes are multiple, really, and those clearly are that the BAME populations clearly are overrepresented within low socioeconomic groups. They live in multi-family and multi-generational households, so there's more risk. There's a disproportionate effect in terms of lower band key worker roles, and BAME communities also actually, ethnic minority communities, do actually have pre-existing conditions such as heart disease, renal disease, hypertension, suffer from strokes, and so on and so forth, and diabetes, and that makes them at higher risk of when they actually then come across a virus to be hospitalised, and then obviously potentially actually suffer severe consequences as a result. Next slide, please. So this is just a risk framework that we developed just to contextualize this really in terms of the actual vulnerability framework. So again, the population versus the exposure risk versus the death risk. And this was just one way really that we initially thought we can articulate this in a short kind of framework. Next slide, please. This resulted really in some further work really with our academic colleagues at the University of Leicester, Camlish County. Really, we were asked by the NHS England colleagues through Simon Stevens to actually do a piece of work around risk assessments, really, and we came up with the first risk assessment really for the NHS for staff groups, and what this basically did really was try to actually put some of this in a visual format where we were able to clearly articulate really what those risk factors actually were. And this is available really as a risk reduction kind of framework. And as a result of this, really, it became mandatory really for the NHS to carry out risk assessments for all staff within primary acute care and their community services. And that exercise was actually carried out in July of this year. Next slide, please. So the vulnerability really, I think the report this morning talks about vulnerability rather than ethnicity, and this really sums it up really. So the vulnerability risk really, is expressed really within this chart, and what it basically shows, as you can actually see, really is that there is an increased relative risk by body mass index, by ethnicity, and there are multiple factors that actually at play here. Next slide. The the final point, which is obviously the point I'd like to actually make really is in relation to excuse me, does ethnicity or racism actually play a part in terms of the challenge that we actually face here, and clearly this is obviously contentious, but I think one of the issues clearly is that the report this morning actually says really that that they believe really that the structural determinants of health play a significant, stronger role. So these are structural inequalities, the fact that ethnic minority communities live amongst the most deprived neighbourhoods within the country, in the most deprived wards. So basically that's a pre-existing kind of structural determinant really, which clearly is difficult to actually change. However, basically, Sir Michael Marmot really has clearly said really that he believes that overall health and care inequality does play a part in the overall picture. So I think it's fair to say really that in terms of the issue, you know, I think we will this debate will actually run and run. Clearly, the most important thing really from this slide to actually take really is the action that's actually taken for communities of all vulnerabilities in terms of actually reducing the overall risk to them in terms of their overall health and wealth. So I think that's where I'd like to leave it really this morning. I'm very happy to then obviously later on to actually take any questions that you may actually have within the Q&A panel. So thank you very much for listening, and back over to Hazel. Thank you.
Thank you very much for Abdul. That's so interesting and thought-provoking. What I took from that was, you know, COVID is staying with us. It's really important that we continue to preserve and protect until we get a vaccine, and fingers crossed that a vaccine will be available from early in the new year, should they be approved. Something really important about complacency. I do think people are fatigued. I know, talking to people who have gone through it, who are care staff, are saying, actually, you know, we went through all of this and we are fatigued and yet having to do it all again. So I don't think people are deliberately complacent. I think it's more fatigue, you know, but we have to really, really guard against that, because it hasn't gone away and it is still deadly, as we know. There's still deaths every day and rising. I think it was also important to point out around the socio-economic factors and the structural and social determinants, and also that people from the BAME community are more likely to have comorbidities. I was also really interested in the vulnerability framework, and selfishly, as somebody who's over 60 but in reasonably good health, I felt a little bit reassured by that. So thank you. So next slide, please, Ed. Yeah, so for the next couple of minutes, I'm now going to be called Sanjeev Bedi, and this is, we kept this in. As I said earlier, Sanjeev couldn't join us today, although he really wanted to, because they have done some fantastic work in Wales. And certainly when Matt and I talked to Abdul early on in kind of May, they were saying to us, actually, the Wales tool looks really, really interesting and good. So what we did think is we would show the video that sort of demonstrates the work that they've done. And then just, there's a slide really looking at their individual self-assessment that I'll just quickly talk you through. Thank you. Thanks, Ed.
Sorry, Ed, could you possibly restart that? We can't hear the audio at this point. My co-host will know this.
Staff. We'll keep our workforce safe. Together, we'll keep our workforce safe. Safeguarding the health and social care workforce in Wales is our priority. the All Wales COVID-19 Workforce Risk Assessment tool is designed to be suitable for use for all health and social care staff. The tool helps you to consider your personal risk factors for COVID-19 and what you can do to help you stay safe. There may be things your employee will need to do. The tool will help you to have the conversation about your risk. 4 simple steps. Step 1. Check your risk. Consider each risk factor that applies to you and total your score. The tool signposts to a range of health and well-being resources to help you consider how each risk factor applies to you and actions you can take to stay safe. All information gathered here will remain confidential. Step 2. Understand your risk and what your score means. Depending on your workplace setting, your score could mean that you are low risk and can continue with caution. This means making sure to follow the advice that keeps us all safe. Good hand hygiene, social distancing, correct use of PPE, ensuring the right training to protect staff and patients. Those at high risk or very high risk will require a wider review. Simply use the tool to highlight where you are positioned. Step 3. Identify the right actions for you. When you complete steps 1 and 2, it is important you contact your line manager or employer to discuss ways to ensure that you are protected as much as possible. Step 4. Act now. Take the right actions. It is important that the actions you agree with your line manager to mitigate and minimize your risk are recorded, and a date is set for them to be reviewed with you.
Thanks. Can we have the next slide, please, Ed? Thank you. So just wanted to quickly for you to have a quick look at what the risk assessment tool is that they use in Wales. It is a self-assessment that you do online, and it's confidential, and it's been put online by the Welsh Government. And as you can see, it looks through your risk factors, your gender, your ethnicity, any existing health conditions, and there's a range set out of there, your BMI and your family history as well. So, and actually what happens on the basis of that, and then there's a score, you'll see the scores down the side of the screen, and that will let you know whether you are at risk or not. And then at that point, you would talk to your line manager about what mitigations you could put in place to enable you to continue at work. So it's a really helpful tool. I think we can probably share this, Leah, as well, the tool afterwards. So I think it's just worth looking at. It seems to be what's really important. Can I just check that everybody's on mute? Thank you. I was echoing there. It's really important. What's really good about this toolkit actually is that, as they can see, as the risks emerging, the risk register changes and the scores change, because they can see what, as more and more instances are happening, we can really see what happens. So I think we're not recommending it, we're just saying it's a really good tool for you to look at, and certainly as a self-assessment, I think that's a really good, I personally think that's a really good idea. Okay, can we move on, please? Thanks, Ed. Yes, I'd like to now introduce Anushka Kamali, who's the Development Officer at 360 Degrees Healthcare and Rehabilitation Services Limited. She's going to talk to us about her own experience as a member of the BAME community, talking about how she went through a risk assessment and then how she supported others in the risk assessment approach at her in her organisation. So over to you, Anushka.
Hi everyone, just making sure you can hear me, Hazel.
Yes, we can hear you.
Hi, I'm the Development Officer for 360 Degrees Healthcare. We are a domiciliary care and support company, and we're based in the East Lancashire area. We, at the start of COVID, like everyone, felt that locally and nationally there wasn't very many policies in place And as a care and support worker myself, I've worked for 360 for 5 years. I've also been the development officer for nearly 2 years. So I work in the office and also do care and support. I felt myself personally that we just kind of got flung into a scenario and situation that was scary to us all. And if it was scary to me, who worked in the office, and it was scary to those who worked out in other people's homes, discussing their own personal lives and things with other people, how could we as an organisation support our staff? Now, I know personally from my lived-in experience, I live with my family, as many of the BAME community do. We very much believe in kind of support systems and kind of bigger households. It's naturally an evolvement that's a process that's always happened. We kind of realised, and I realised, well, this disease, I could end up taking that home to my family, family that got a history of diabetes, a sister that's in the most vulnerable category that I live with, and also extended members of the family. So I've got members of my family with cancer and things like that. So something like COVID-19, for me back in March, was a really, really scary experience. It wasn't something like cancer that I would not be potentially taking home to my family, but this I could. And we felt as an organisation that we needed to support our staff. So what we did, we kind of developed a risk assessment, a bit like the Wales risk assessment tool. And within that, we pointed out factors such as who do you live with? What's your financial income and things like that? Are you struggling? If you kind of got COVID and had to isolate for 2 weeks, how could we as a company assist you and help you? And we'd never had to ask our staff these questions before. It was a new experience for us all. So what my registered manager did and what my managing director did, they actually brought me into the office like I do every other day. And we sat down and we discussed what, as a care and support worker, so take your head off the development officer role, look at the care and support worker role. What would you feel as a care and support worker that you would need assistance from us with? So we kind of all sat down as a three and discussed how we could support our staff and how we could make our staff feel comfortable. So what we did, I was the first person to discuss and pilot this risk assessment tool that we'd conducted. And then once we piloted the risk assessment tool with myself, I then rang approximately 18 members of staff and did the risk assessment tool with them. They were all from a BAME background, however, they also had other vulnerabilities, such as myself. I've got asthma. So staff also have asthma. I could link quite well with them and say that our struggles and worries, because if I don't take my inhaler on a daily basis, I do struggle. And then if I was to not wear my PPE, not wear my masks, how would that kind of affect me and the people that I'm living with? Because when it comes to COVID-19, that's what we're all thinking about. Actually, it's not me that I'm potentially affecting, it's everyone else. So what we did, after we conducted the risk assessment tool with these 18 members of staff, we then discussed geographically and kind of looked at national policies that were going on at the time. So we realised that we then could have support bubbles. So we thought, actually, how can we introduce support bubbles within a domiciliary care company? So what we did with the 18 members of staff, we split them up. So we thought, who's got asthma, who's got other vulnerabilities that might affect them in different ways, and who can kind of discuss other things. So with that, we then introduced Microsoft Teams and Zooms, and with the 18 members of staff, we had 4 support bubbles. So we had a group of those with asthma, we had a group of those with more severe difficulties, just so they could kind of have a discussion with their team and feel comfortable. Because I think what I felt throughout COVID-19 is that I'm not alone. There's a lot of other people of BAME community out there facing the same difficulties as myself, that are worried on a daily basis that I might be affecting other members of my family. So then after we introduced the support bubbles, we then moved on to kind of a regular one-to-one meetings, whether this was me and them via Zoom, just to do a kind of catch up, because obviously these risk assessments were conducted in wave 1. And as Abdul said, wave 1 is completely different to wave 2. And then going forward, it will be completely different again. So we need to ensure that we're constantly following the national and local policies. I know, especially being based in the East Lancashire area, our office is based in Nelson, and we're obviously we're all very high tier at the moment, but there was one point where Nelson and Burnley were extremely high. So within them times, it was my duty, because I understood what my staff were feeling, actually have these discussions with them and actually ask my staff, if there's anything that we can do to support you, what actually should that be? So after we did the bubbles, we did the risk assessment tool, we've had the regular one-to-one meetings, we've also realised that it's important to keep a weekly update and a weekly change. So I will email staff weekly just to say, how are you feeling? How are you feeling this week? Have you got any concerns, any worries, anything that you want to talk to me about? And what we found as an organisation is it worked quite well for us being able to talk to our staff. For one, as explained before, I work in the office, but I also go out on care and support. For 2, I'm BAME. For 3, I've got a vulnerability, I'm asthmatic. And for 4, that I'm just a normal person. I didn't speak to people on a management level. I said, how are you feeling? How are you doing? Because it's quite important to kind of have that kind of discussion with people and just ensure that they feel comfortable talking to you. Because especially within our risk assessment tools and our bubbles, we ask quite personal questions like, has your mum got a vulnerability? Has your dad got a vulnerability? Has your children got a vulnerability? And they're not necessarily questions that we would ask at a normal supervision or a normal meeting. So it's quite important as a top tip to ensure that we kind of make our staff feel comfortable within their role, because we're expecting them to provide care and support to the most vulnerable in society. Well, they might need support themselves, especially at this difficult time. So yeah, that's all I really want to say today. I just believe, as a top tip from myself, just be yourself. If you're going to be, I think it was quite shocking for me at the poll, which I thought was an amazing idea at the beginning, that quite a few of you said that you've not done risk assessments with BAME and vulnerable. And for me, we're now into the second wave of the pandemic. We've nearly gone the whole year with COVID in our lives. It's a daily news topic. And I think for me, it's quite important that we realise that our staff may be struggling and they might just want that support from a normal member of the management team, from a normal care and support worker. And I think we need to be approachable and we need to ensure that staff can just come to us even after we've done the risk assessments and the bubbles. As Abdul explained, going into wave 3 and wave 4, because with long COVID and all the new issues that are arising, we need staff to feel comfortable. Because if we don't have them staff, we can't provide a service for the most vulnerable in society. So yeah, if you've got any questions for me and any questions that you want to ask more about our risk assessment tool, feel free, as Hazel said, to put it in the chat box. But yeah, that's all I've got to say for today, and I hope you have a lovely day.
Thank you very much for that, Anushka. I'd muted myself. Yeah, what I took from that really is about making sure that staff feel comfortable when you're doing this, and And the approach your organisation took through yourself really was about being supportive and approachable, and the careful think about how you might use bubbles and what the risk assessments might look like. So thank you very much for that, Anushka. I'd now like to introduce Valerie Reid. Valerie works for the Manchester Health and Care organisation, and she works in an integrated team and is a reablement review team officer. I actually worked with Valerie many years ago, so I know her well. So over to you, Valerie, if you could, next slide, please, Ed. Oh, have we lost Valerie?
Nope, I'm here.
Oh, good, I'm glad to see you.
Hi, everybody. So, as Hazel's already introduced me, my name's Valerie Reid Fogar. I'm one of the reablement support officers, review officers. So I don't actually give support, but I do review the support that's provided throughout the South Manchester area. We actually launched our Manchester tool, a reablement tool, in March this year, it was late and it was necessary because of the concerns for our staff members. And for me, as a reablement review officer, I'm a trusted assessor, so it means that my assessments have to be trustworthy. It also means that I'm trying to reassure the community when I go into homes or hospitals or wherever it may be in the community, that I can reassure people that I'm going to help rehabilitate them. So COVID brought on a number of issues that were really quite scary, and did cause quite traumatic responses for the service that we do provide. So because we are a joint integrated service, health and social care service, it was paramount that we continue. This isn't a new pilot service. We have been up and running for around 3-4 years now, from the north over to central and in the south now, where we work together with the social services and with the NHS. So again, the fact that a majority of our work is with the hospitals, the community health services, and again, with the community itself. I'd have to really say that the focus on BAME, it was the main focus when we launched the tool in April, but it covered everyone across the board. However, it gave BAME sector priority. This being that we had to become, and we made ourselves more aware of the underlying dangers for us as members of the BAME community. And it's changing and it's updating continually. It has to be, we are screening and updating continually. Part of the range of support for the staff who are high risk was that we screened everybody, and we continue to do this, not just on a weekly, but now a more daily basis, dependent on what their interaction is, whether it be from the hospital or whether it be in the community. As we work with the D2A, which is the discharge team, who are based in the hospital, we have to be able to screen not only workers, not only patients that are being discharged, but also the staff that are going to be working with them. So that meant that we had to really, it was very quick thinking of our managers. I must mention Anthony Petro and also Paul, and even Bernadette Enright, the director, got on board to support us in doing this and how we could do it in a time specified cause, and also to make sure, again, we highlighted and provided the safety of all involved. So that included one-to-one sessions with our managers and also with our support workers. I actually have the management authorization. I manage nearly 70 members of staff, which are support workers, which are 50% of BAME. So that meant that I had to have some type of communication with them because of the scare factor. People were scared to meet, people were scared to leave their homes, and yet so committed, still were willing to go out and work in the community. So that meant getting PPE kit to staff. It also meant making sure that we were on a continual communication where we were able to communicate via whether it was social distancing in the community or whether it was virtual or whether it was in a appropriate office in the building which accommodated social distancing. I personally, my personal experience was, I have to say, outstanding, because my senior manager made the provision of coming to see me at my home on a social distance level where we met. I left paperwork for him in front of me. He could see it. He left PPE kit for me, and we did the same in dispersing this to staff members. This COVID-19, I don't think the awareness throughout the BAME community is as received as it should be. However, I think as a member of the BAME community, we are, as Anushka's already stated, our culture brings us very close together. Our lifestyle is very much close knitted. So it has affected us in a way where we've had to bubble safely. We've had to make sure that it's been explained to members of family and community what we can and cannot do for our own personal safety, and obviously for other people's who we're interacting with. Moving on quickly, what I learned from my senior management has been imperative to the fact that the regular reviews, the regular updates, the signposting to services which Anushka's mentioned, and I think Abdullah's mentioned as well, for support, for financial support, for counseling, psychological support, even for things like for vulnerable individuals that at one stage they were able to get out and collect prescriptions from their GP or from their local pharmacy and weren't able to do that since the COVID, since March. So it was really making people aware of services that were available. Even though these services were strained, people have been excellent in going above and beyond in delivering information and delivering medication that is needed. Again, I'd have to say that the integrated service, it had come in just at the right time, because working together has been, it's been paramount to making sure people have been discharged out of the hospital, have received the service and the support that they need, and the staff that are providing that service are continually being screened, being supported, and still providing a service that's paramount to people's health in this environment now, in the stage that we find ourselves now. Overall, ensuring staff were able to continue to deliver essential services safely, we had to also set up workshops which were done on a virtual basis to really show people, I mean, what we might take for granted as the PPE assessments and how to perform PPE safety, putting on PPE equipment and discarding it safely. Yes, we all, most of us, or we all at this stage, I would expect, know the paramount need to wash hands, to refrain from touching nose and mouth. to cover the face, put the masks on when we're outside. But also it was about people being aware of how cross-contamination can take place so easily. So again, it was about the awareness. Regular communication has made this work so well. And again, I would say building a great rapport and trust with not only the management, but with the community on a whole. It's helped us no end, and it continues to assist us with the provision of the service that we provide. The other thing was symptoms. I don't know if it's the same across the board, but symptoms have seemed to change and enhance as the COVID-19 pandemic disease has continued to grow, to manifest. So the symptoms changed. In April, March, we were looking at the government released symptoms, but by April, May, we were looking at different symptoms, and having the opportunity to be tested was paramount. And not only having the opportunity to be COVID tested, but then to also have the opportunity to have the antibody test as well, just to see whether people had already contracted the COVID disease and whether they'd actually come through it. Having said that, there's many people that have COVID-19 and are still going through the process, but going through their day-to-day processes, but haven't actually shown any great symptoms, but they've been tested and they've had the antibody test to confirm that they have had the COVID-19 disease. On that note, I'd really like to take this opportunity to thank all services. Every service has been tremendous in supporting, whether it be delivering food parcels, whether it be delivering medication, whether it be delivering a service on a whole. I think all parties have been really outstanding. And I'm available to ask any questions at the end of this. Again, I'd like to thank everybody who's supported. Hazel, it's a great platform for people to be aware of what's actually happening and what's available. So yes, I'm available for questions at the end, and thank you for listening.
Thank you ever so much, Valerie. That was really interesting to hear. What I took from that is there's a number of things really, was around staff delivering over and above. We've heard about that all through this pandemic across all of our sectors, around care staff who have done over and above what they should do. I think this is where I was talking earlier about fatigue. Actually, you know, people have gone through one big surge, had a tiny lull, and for those of us in the Northwest, we've been in restrictions for what seems forever. And how important it is that we recognise the work that people do and continue to do, and under really difficult circumstances. I think what I found interesting from both yours and Anushka's talk was around the link to families. You know, Anushka talked about her family where there's some, you know, where people have some conditions, and actually you having to explain to your own family what you can and can't do with respect to work, and thinking about how you keep your family safe, but also you keep your work safe as well. So that sounds really interesting. The work around regular reviews, and actually the stuff about regular communications couldn't be more important, especially as you said, looking for symptoms changed, guidance changed, about really thinking about that continual focus on getting the PPE right, etc. But most of all, what I've taken from both of yours presentations is about the building of trust and how important that is. If you're going to do this properly, then you really have to build up the trust with your staff in order to be able to do that. So thank you very much, Anushka and Valerie. Please could I then move the slides on, and I'm going to introduce Leah. Leah is the program director at Northwest ADASS. I think she's the program manager. Actually, I don't want to promote you without letting Matt know at least in advance. So she's the program manager at Northwest ADASS, and she, along with Safina, who you will hear from later, have done a lot of work on the toolkit that we're now going to talk through. So next slide, please, Ed.
Thanks, Ed. Not least for moving us off that one, because my programme director is also on the call, so I'm sure this will come up in my one-to-one. So in terms of the toolkit that we at Northwest ADASS have produced, a tiny bit further context for this, I think. This was being developed, or at least the idea for this emerged at a point when we were also developing some resources for managers and employers in adult social care to support their workforce with kind of mental health and wellbeing at this time. And it had struck us, not least as a group of people involved in the sector and working quite broadly across the sector, that given the huge range of organisations and teams and services that are included in adult social care, you couldn't always expect that they would have at their disposal kind of teams or individuals who could take a lead role, who had experience in doing similar pieces of work. We obviously include quite a number of quite small organisations as well. So what we really wanted to do was provide something that was incredibly practical, very concise, and would provide a resource for employers, for managers who are flat out at the moment, aren't you, in terms of the work and responding to COVID and delivering within this environment. So it needed to be something really accessible. It needed to be something quite concise. And we wanted to essentially just pack it with as many helpful resources as we could find to support individuals and organisations to develop things that were going to work for them. So our approach was absolutely underpinned by research in terms of best practice models, and we got a number of kind of recommendations in terms of things that work. The All Wales example that we included came highly recommended from a number of colleagues across the region, so that was something that we really wanted to include. We also did engage with a range of organisations and staff as we were developing this and pulling it together. We had a project team who included a huge range of colleagues, from kind of registered managers to colleagues such as Anushka with lived experience, and Abdul supported us through the development of this as well. And where we really wanted to take that from was an understanding of the concerns and barriers for our Black, Asian and minority ethnic staff. And again, coming back to that point, we understand that everybody is busy and working at 1,000,000 miles an hour at this point, but we felt very strongly, and I think certainly from Abdul's presentation, I hope you'll agree, that the urgency and the importance of this absolutely needs a response right across the sector. So given the pressures, how can we do something that was going to help people respond helpfully in this? So the key principles of the work then, of the toolkit, were really about the focus on Black, Asian and minority ethnic, but within the context of a wider risk assessment approach for vulnerable and at-risk groups. So obviously also kind of thinking about how similar approaches are going to work for people with underlying health conditions, who are slightly older, and also men within the workforce as well, and particular risks around those, as they were highlighted earlier in the pandemic. The second principle for us was absolutely that this was to ensure that we could support our workforce to stay in work safely. So not provide something that would almost kind of lead to a blanket approach of kind of removing people from the front line if they could be supported to do something safely, but similarly ensuring that they are safe and that they feel comfortable with that as well. So that point about staying in work safely. We absolutely wanted to take a kind of a data-led and evidence-based approach to the extent that that's possible with such a new disease, and as we are continually learning, trying to kind of flex and respond to that. And the other principle for this toolkit as well is that it should support managers to have those individual conversations. And I think from Anushka and from Valerie's experiences, and also the Wales approach, that emphasis on this being about individual conversations and that for managers to have with their staff. Next slide, please. So the toolkit itself, I hope you'll have received a link to that via the Eventbrite updates that were sent yesterday and today. So you should be able to access that on the Northwest ADASS site. As I said, it's reasonably concise. It's just a few pages. We've really attempted to make this really very practical. We provide links to examples of risk assessments from a range of sectors across health and social care. So it's limited to health and social care, but looking at local authority-led approaches, integrated health and social care approaches, approaches that are developed at kind of more of an ICS type level. So trying to provide a range of approaches there that employers and managers can kind of pick and mix to suit their own circumstances. What we've tried to also do is ensure that there's some information there about kind of appropriate mitigations, because key to all of this is going to be what happens at the end of the risk assessment and what are the mitigations that can be put in place. So trying to provide links that give some inspiration around some of those mitigations as well. We also included a case study there in terms of the 360-degree healthcare approach that was taken, that Nishka's spoken about as well. And what we then followed that with is some kind of tips based on experiences of managers and organisations that had already started this process. So the toolkit is there on our site. Really hope you find that helpful. Do please get in touch if anybody has any feedback. And certainly questions coming up shortly after the Q&A. We'll be really interested to hear from colleagues, particularly those working in organisations that haven't yet started this process of risk management and mitigation for vulnerable groups within their workforce. How you feel about what you've got at your disposal now, and whether you feel you need more in order to progress this. So those are questions that we'd like to explore after Q&A. But thank you.
Thank you very much, Leah. Could we go to the next slide? So thank you ever so much for that. And the toolkit is really, really excellent. And I just want to again thank Leah and Safina for all the work that they've put into that. So we now have the panel, which is made up of our speakers, which is Abdul, Anushka, Leah, Valerie, as well as Safina Nadine, who's the Head of Diversity and Inclusion at CQC. So we haven't had a lot of questions in the chat yet, and that's okay. But if you do have anything, put them in. And we have had a couple of comments, which I will come back to. But we did run a previous webinar where we did get a number of questions, which actually might be helpful for you to hear the answers to those. So Safina, just to put you on the spot, just like I did last time, just a question really about CQC and what they are looking for, really. What kind of things would they be looking for in their inspections in terms of expectations around this?
Hi, oh sorry, can people hear me and see me?
Yes, we can hear you. Can't see you yet though.
Oh, okay, I've got my video on, so I don't know what's happened there. Sorry, can you repeat that? I was trying to get onto the
Safina, could you just talk through what the expectations are of CQC when they'll be looking at what their expectation is around risk assessments in this area?
Yeah, sure. I think there's been a lot of work throughout the pandemic around CQC. So although traditional inspections were not taking place. There was lots of kind of phone calls and links with relationship managers and CQC. So as well as making sure that we're keeping our people safe, service users and patients, the questions from the relationship managers was around how are we ensuring that staff are kept safe and what risk assessments are being taken place. So it's something that we've been looking at throughout the whole of the pandemic, and it will be kind of part of the kind of inspection process as we carry on through working in a different way, and now we're doing on-site inspections as well. So it is, we are keen to find out what's happening, what kind of risk assessments are being taken place, and what mitigating actions are put in place to protect all staff, including BME staff and service users as well.
Okay, thank you very much, Safina. The question for Valerie, and then perhaps Anushka as well. Can you just talk to us about the top things to avoid when developing a risk assessment approach? So this is kind of, if you are doing this, and you should be, what things would you avoid? Anushka, can you go first?
So we didn't find that we really needed to avoid anything. It was how we worded stuff. So for example, if you're asking someone about financially, how are they coping? Don't say how much money have you got in your bank account at this moment in time. Kind of wing it into conversation. So I had someone actually send me a private question, which kind of links to this as well. We found that so within the private question, it actually says how it was similar to what you've just asked. So we kind of it wasn't really do not put this in and do not put that in. Just if you've got that trust, and if you've got going back to that bubble and going back to my lived experience, it was just making sure someone feels comfortable. So what we would do, our risk assessments literally took 5 to 10 minutes over the phone, because we started it as a general chat. I'm not sure if you did yours the same, Valerie, but it was just, how are you feeling today? Have you got any worries, any struggles? Casual chat, and you found from the casual chat that people would then discuss what their struggles were, whether it was financially or whether it was personally. So that's how we kind of went about it. So it wasn't like we were kind of looking at our risk assessment and saying, this is what you need to do, this is what you need to do, this is it. It was more, how are you doing today? How are you feeling about COVID? I'll lead on to you, Valerie. I'm not sure if you want to expand.
I think I'd agree with you totally there. It is specifically paramountly about the approach, and that stems back to the importance of the rapport that we already had, but has, again, it's manifested and even grown during the COVID pandemic situation. But again, one of the things that I can give a personal example, there are individuals, and I don't know if this has been the same for you, Anushka, where people have been so scared, in fact, to the point of paranoia, that they'd call really to get some advice, but really apprehensive in asking because of fear of being stigmatized, or fear of being regarded as being over emotional or overacting. And one of the things that I found helped was awareness, sharing the awareness with our family, friends and colleagues of how to, for one, building up your immune system. I mean, it's something that we've kind of overlooked during our discussion this morning, but in preparation to deal with this pandemic, this COVID disease, is, building up your immune system, especially for BAME. So it was simple things like, have more fruit. Hazel mentioned the issue of fatigue. People have been very fatigued, very lethargic, very tired, and are working above and beyond, as I've already stated. So having the immune system built up, it prepared us, and it continues to prepare us to provide the service that we need to provide. But it is paramountly, you know, and profoundly about how we actually discuss, how we talk to each other, and how we make information available. Sometimes it was about doing a generic slide about there is support for finance. For instance, certain organizations were providing finance and information, counseling on money advice, financial advisory. So it was about making that information available, giving it generically to everybody, word of mouth, email, text, links, really about sharing as soon as you got vital information that would help somebody to share it.
Thank you. Thanks very much. Can I just ask, there's a question come up in the chat, which I think is really an interesting one. And again, it's for you too, really. How did you carry out the risk assessments for the BAME group without them feeling discriminated against, Valerie?
We prepared them via a discussion before actually having, there was a generic message that went out that we needed to have these risk assessments. And then each individual was given the option to calendar book, invite themselves and us for the actual risk assessment. And we did express that it needed to be done within a period of time. So it was for everybody. But again, as I mentioned, when I was giving my presentation, it was about not making people feel that vulnerable, but also about addressing the priority of the need for BAME, people of the BAME sector. So the risk assessment was really, we had to prepare people for the risk assessment. And again, like Anushka said, it was about asking the questions. On my slide, we actually had a format, a reablement toolkit format, which we asked specific things at a specific time, and we asked them what was appropriate for them. How do they want to have this risk assessment take place?
Thank you, Valerie. That's really helpful. Is there anything you can add to that, Anushka?
Yeah, I think just adding to that, we didn't feel, because obviously it was me doing it with my lived experience, we didn't actually find that we had the problem that people felt kind of excluded. They actually were really willing to take part. We kind of just said it. So we automatically know, as discussed earlier, we already know that you're kind of more vulnerable. I'm more vulnerable being asthmatic. I just need to have a quick chat with you if that's okay. And they were like, yeah, that's no problem at all. What we actually found, we found that people that weren't BAME felt kind of that exclusion. So we kind of, I see Valerie nodding her head there. So we kind of opened it across the board as well, and made sure that everyone felt included. And I know I had a private message about the bubbles. So everything what Valerie's just discussed about nutrition and things like that, we saw the need to obviously introduce these bubbles. And the private message actually said, how often did the bubbles actually come together? And the bubbles actually, because it was their bubble, wasn't our bubble from the office point of view, it was your bubble. You're the ones in that lived in experience. Yes, I will join it because I'm also part of that lived in experience, but it is not my bubble as a development officer. So we found that obviously within that bubble, they felt more comfortable saying, not having that paranoia. I know I actually had a staff member ring me once at 8 o'clock in the morning, saying I'm really scared to go to work today because of my anxiety, because of my paranoia, because of COVID. And she wasn't actually BAME, but we then introduced her into the bubble. So it was important for us that all staff felt included as well.
Thank you, Anushka. That's really helpful. I've got a couple of questions for Abdul now. Abdul, can we discuss how you deal with apathy, organisational apathy, and how to keep the risk awareness of BAME individuals as a high priority? Abdul?
Yeah, thank you. Thank you very much for that, really. I think the most important thing really around organisational awareness and to keep the agenda going really clearly, it's important really that there's influences really within the officer cohort as well as practitioners really, and clearly it's by having staff groups, it's actually by having the leadership really clearly within the adult social care. So in Lancashire County Council, clearly the adult social care cell that's been formed across the upper tier authorities clearly has this at the heart of its strategy. It discusses it on an ongoing basis. It's not a one-off thing. It's part of that, the continual process. It's now weaved in, and clearly every opportunity, and there is a designated piece of work in terms of a system conversation. So that clearly is by, so the way we've done it in Lancashire clearly is we've had regular webinars with the care sector overall, not only the local authority elements of it, but broader care sector and the workforce around this very issue. So to keep the discussion and dialogue going, as Anishka has actually kind of highlighted, and Valerie as well, the issue clearly is, in terms of actually keeping it on the radar, I think clearly vulnerabilities, COVID is not going to go anywhere. So it requires all of us as champions to clearly make sure really that this doesn't clearly go off the boil, and we continue to raise and to preserve and protect our staff and our workforce as throughout this very difficult period, and to monitor this really through evidence, and that's both formal and informal. So we need the feedback really from our workforce in terms of their lived experiences. We need those stories without fear or favour, and it's the culture really within organisations and systems that we create, and how we can improve that's actually going to make the biggest difference in the immediate and longer term.
Thank you, Abdul. I think it's really important what you've said there around championing this so that it doesn't go off the radar, because we were asked on the previous webinar about ethnicity being one of several significant risk factors and why we're focusing on that. And I think we're focusing on that because we've seen a predominant impact on that area. But that's not to say is that there are not vulnerabilities that we would be taking into account, and we need to keep them all really high on the radar, don't we?
We do indeed, really, and clearly, the most important thing really clearly around this really is we need to focus our energies on obviously the immediate task at hand in terms of caring and preserving the life of both our workforce, but also our residents and communities that we serve through our professional careers. But I think the most important thing really is, what is our end game here really? What are we trying to achieve? What's our clear aspiration point? The aspiration point really throughout COVID and post-COVID is to make sure really that what we create for the future is better than what we actually had pre-COVID. And that really would leave a very strong legacy for future generations and for future communities. So how we do that is a journey that we're actually all on really. So our workforce from BAME communities need to be, so you might say, well, Abdul, what does that mean really? Well, our workforce needs to be more confident. It needs to clearly have the tools to do the job. It clearly needs standards raising. It needs where there is discrimination and where there is disadvantage, for that to be addressed and not look the other way, to call out those issues across all range of vulnerabilities and disadvantage and across all population groups is something really that we all strive for. It's a common human aspiration. So therefore, we've got a common duty to actually do that on behalf of us all and for the people that we serve.
Thank you, Abdul. Well, you've certainly inspired me to make sure that I continue to be a champion. Roger's put up a question actually, which I'd just be interested in Valerie and Anushka's views on this. It's the fear of some providers in relation to some staff may abuse medical suspension or answer questions in a way to achieve favourable working. Did you see any examples of this? Valerie, could you go first? You're on mute, Valerie.
Is that better? Can you hear me now?
Yes, I can hear you.
Okay, I personally didn't experience that, and I haven't had feedback of that from staff. However, I've had the opposite actually. Staff have actually voiced how much they feel that they have been prioritised with regards to the BAME sector of making sure that they were prepared in a certain way and treated a certain way because of their vulnerability. So as I mentioned before, the screening, the repeated screening, on the other hand, people that weren't of the BAME, as I think Anushka's mentioned, were saying, you know, well, why should they be prioritized? Because we are all vulnerable across the board. But once it was voiced and shared across the board that BAME were more vulnerable and more susceptible to contracting this pandemic, this COVID-19, that was actually explained away. However, there were some community members, patients, that, to me, from what was actually relayed to me, that didn't want, they actually called me directly and said they didn't want the support and they would self-isolate because some of their support workers were of the BAME sector.
Oh, that's interesting. That is really interesting. How did you handle that?
Well, we provided the service as we could, because if we have the capacity to do what the client or the patient has requested, we will provide that service. If we don't, we explain clearly that we can't. It's about giving clarity to what the requests are and making sure that the requests are clear, and really also being not biased with regards to people's situations, individuals that have come out of hospital and already feel vulnerable. And then some will state they prefer to have a BAME support worker who they're used to, but they also want to know how many other people is that support worker going in to see, which is obviously confidential. But what we did do was we isolated certain workers to work with certain individuals in a certain area. So that literally put a bubble in that area with the community, with the staff.
That sounds like a really good way of doing it, actually, really helpful. Anushka?
I think I just want to add to what Valerie said, really. We haven't found this. I think it's the way we kind of recruit on person-centred values. So all our staff want to work, and even those that have been ill have wanted to work, and we've actually said to them, no, you need to isolate, you are ill. And I think it's just going back to that point that I built about trust. You need to have that healthy communication within your organisation, and you need people to be able to feel comfortable enough to come and talk to you about things. And I think that's why we've not, linking back to the question, felt that anybody has abused medical suspension or answered questions in way to achieve favourable working. When I actually started doing the risk assessments, I was like, oh, everyone's going to say they're really unwell, they don't want to wear a mask. We've actually had the complete opposite. People are like, yeah, I want to work as many hours as possible, I'm supporting the vulnerable, I'm happy and comfortable within my job. So we've actually not experienced that either. Okay, that's brilliant, thank you very much. So I have one final question, I think, before we move on to next steps. And again, I think that's for Valerie and Anushka. Sorry, I'm not picking on you both. So when people have come to you in absolute tears and said, I am really, really scared. I'm really scared of coming back to work.
I'm really worried about COVID. I'm worried about taking it back to my family. How have you dealt with that? And I'll take Anushka first this time.
We've sat with them, kind of had a mini supervision with them, whether that's via Zoom or at a social distance point of view, and just said to them, do you want to reduce your working hours? What can we do? As an organisation, we've got to be there to support people if we want to keep our staff, especially in these times of need. We can't afford, and I'm sure Valerie's probably thinking the same, to lose staff at this very point in time. So just try and work with them. If they need a week off, say you can have the week off. Let's get you to a point where you feel comfortable working again. No, just going back to my lived experience, right at the beginning, I kind of had a personal discussion with my managing director about the way I felt, and she made me feel really comfortable. So I took that from when, if a staff member's come into me crying, what can I do to make them feel comfortable? What can I do to make sure that we're not losing a staff member, we're still protecting the most vulnerable in society, and we're still having that trust and open communication. And I think that's the most important thing that comes out of this, really. It's that kind of, I think Abdul mentioned it before, that I wanted to add to, about the longevity of these risk assessment tools. And actually, when COVID's over, whenever that may be, we then might experience something else, and then something else, and then something else. So this has been a whole learning experience for us, and a whole learning process. So I think we can't make our staff feel comfortable if we don't have that open discussion with them.
Okay, thank you. Valerie, how have you dealt with staff who've been really anxious and upset?
I think overall, I'd have to say at the outset is one of the things that has become quite prevalent in this period of time is that this vocation of a duty of care has really manifested. People do this job because they care, first and foremost. But in regards to the question that you've asked, I have had that experience of staff coming towards me and being very, very scared, even to the point of maybe seeming or portraying to be paranoid. The first thing that we did was, again, similar to Anushka, we gave the individual time and space to actually speak with us on their grounds, how they wanted to speak with us. Was it social distancing? Was it via just a simple telephone call? Was it a Google chat? How they wanted, they made the choice. And the other thing that we did straight away, we made it available that people could take the test. At that time, we had a link where people could literally access a link through a health centre, their local health centre. And because they were NHS workers, directed workers, they were able via MCC with the integrated service to get priority for a test. So to rule out the fact that they may have thought that they'd actually contracted COVID, we introduced and invited them to think about what they wanted to do, but remind them in the interim period that it would be safer for them and for their family members and for obviously their work colleagues, if they wanted to continue to work, to have this test, which once they'd had the test, literally were a different person, because of all the tests that I'm aware of, they all came back negative, and they all appreciated and said, well, why don't we have the tests more often? And that's something that I would like to bring up now, and probably I think it's a good thing that the workforce, the frontline workers and people that are working in the community have that advantage of being able to have a COVID test, even if it's once every 7 days, once every 14 days, whichever adequately addresses their work and their safety.
Thank you, Valerie. Thank you. It's a really important point there as well. So I think that's the last question that we have from the from our chat. But I would like to ask Safina another question. Safina, if you can hear me, I'd like to ask a question about whistleblowing. Have people come forward to say their concerns are not being taken seriously by employers to CQC? Are you aware of any?
I'm not really aware of any. I know there has been concerns raised. I chair the Northwest Equality, Diversity and Inclusion Forum, and I'm hearing lots of stories around Black and minority ethnic staff feeling raising concerns. But in the NHS we have freedom to speak up guardians, and I know they get a lot of queries and concerns. Again, in social care, what mechanisms do people have to raise any concerns around the issue of not being feeling safe, or people not understanding the importance of this and not doing the risk assessment, or not reviewing the risk assessment properly. So I think for me, when we're looking at developing the toolkit, one of the things that was raised when we were engaging was what happens when where do people go when they don't have that understanding. Organisations like Anushka's and Valerie's, where do people go to raise that, and what can be done in a really safe way? So we did pick that up a lot. So I'm hearing people saying, I'm not feeling safe, I've not got the right PPE, my manager's not taking this seriously, through a lot of the engagement I do through my role as a chair of the network. So I think it is an issue, and I think managers on the call and wider need to be mindful of that, and trying to put in mechanisms for people to raise concerns.
Thank you, Safina. I think that's our next piece of work, probably, in terms of how we take this forward. I'd just like to thank all of our panel, Abdul, Anushka, Safina and Leah, and for me it's lovely to see Valerie again after so long. It was so lovely to see that lovely smiling face.
Thank you, Hazel.
If we could just go on to the next slide. Ed? Right, so we've got another Zoom poll question. So I'm going to ask Leah to talk us through this because I'm technologically inept. Leah?
Okay, well, actually, I think we've had a query if we could revisit the previous poll as well, and that might be quite helpful for us in terms of moving on. So just to quickly recap, the poll that we opened right at the beginning of the session was just trying to understand across those attendees whether their organisations were currently undertaking some of that risk assessment, management and mitigation activity. And we can see here that a good proportion of those who responded were from organisations that were already starting to do that. We did see some that were maybe in progress, but also interestingly some that it didn't seem to be happening at this point. And so what we'd like to understand now with our next poll is actually where colleagues attending today's event are up to now in terms of what your next steps are. So colleagues should now see a little pop-up Zoom. I can see people are filling it in already, to just quickly poll in terms of how confident you're feeling in terms of the approach maybe you've already got in place in your organisation or that you're developing within your organisation, so that we can get a sense of where colleagues are up to. And I can see we've got a lot of responses here. There are definitely some that are still saying they feel like we've got a really good plan in place. We know what we need to do, but there's still a bit of work to be done. I really hope you found today's session helpful for some of that. Really glad to see that we've got a good proportion. We've got over a third so far saying that they're confident in their approach, but we do still have one colleague who, and I should point out, obviously this is all anonymous, who's still not quite sure how that's going to happen within their organisation. So some really helpful insight for us to reflect on here. And if we could move on to the next poll as well. So we just have one further question then, particularly for that colleague who is still not sure how they're going to do that, but also for the majority of colleagues who've said that there's still a bit of work to be done within their organisation. We wanted to understand from you if you now feel that you do have everything you need to do this, and if anybody feels that they do still have questions or issues or might require some additional information or support, please do use the chat. We're not obviously able to commit to responding to all of it, but having an understanding of what might help would help us to kind of work out whether that's something that we could respond to. Certainly the whistleblowing point, and Hazel's referenced this, is one that we're really looking at the moment. We know from the NHS Speak Up work that in particular Black, Asian and minority ethnic workforce are less likely to come forward with issues. We know this. So we also recognise that as much as we can do to kind of clarify whistleblowing processes and policies and those pathways, to reassure staff that if they come forward to share their anxieties, their fears, and to raise issues, that they'll be treated in confidence. So that is definitely something that we're looking at. I can see a couple of colleagues have said that they've still got questions or issues. Please do use the chat to let us know what they are, or drop me an email if you don't feel comfortable doing that with your ID attached, as it were. But it's certainly heartening that it looks like we've got a real breadth of attendees now feeling confident, and that they've got kind of everything that they need, or at the very least enough to work with. I think we can probably end the poll there, and I'll hand back Hazel.
Thank you very much, Leah. A really interesting poll. I suppose I can only just reiterate Leah's point around if there's anything else as we moving forward that we can do. As Leah said, we are already starting to think about what whistleblowing might look like for staff who are in adult social care, as opposed to health, where the kind of lines of communication are more fixed, I suppose, really. What we can do about that. But is there anything else, do we think, that we could start supporting with them in terms of our next piece of work? Could you put the slide back up again, please, Ed? Thanks. Okay, while that's happening, I'm just going to talk a little bit about some of the next steps that we are taking before I thank the panel again. So I think what I'd like to do is I'd just like to bring Matt Emerson in. Matt is the programme director who hasn't been demoted, as I can see, and Leah taken his role. I just want to talk a little bit about what we are doing in the Northwest about setting up a BAME assembly to challenge the work that we do. And so Ed, could you take Matt off mute and let him speak for a minute?
I think I'm off mute. Can you hear me?
Yes, we can. Thank you, Matt. So
yeah, I was worried I'd either been promoted or sacked when Liv. So, anyway, I'm still here. Can I just say thanks everyone to who's been involved in producing today. I think it's been a really great session again. So thanks very much, and thanks for everyone who's come along to listen and take part. This really goes back to what Hazel and Abdul were saying right at the very beginning, really, about the overwhelming evidence, really, that we were presented with earlier in the year about the disproportionate impact on our BAME workforce in relation to COVID, and we really wanted to do something proactive in the Northwest to address this. What you've heard today is one aspect of that, but actually, this isn't COVID's not going to go away anytime quickly, and also this isn't just about COVID, but this is about how we listen and work with our BAME workforce and communities, for the long term. So as well as this piece of work, what we are doing, we're establishing an advisory group in the Northwest to help us really to develop our Northwest work around social care. We've just kicked off a strategy, a long-term plan for social care in the Northwest, and so we're really keen that we build in this work into that, and have an advisory group who can help us to deliver that, and make sure that we are listening and taking into account the views and how things impact on our BAME workforce and communities. So we're working very closely with our colleagues in NHS England in the Northwest, who have done loads of work actually on this over the past couple of months, and developed a regional assembly. And we're very much kind of following that work closely, and trying to establish something similar for adult social care in the Northwest. So we're still in the early days of doing that, but we have one of our directors is leading that. So that's Valerie's director, Bernie Enright in Manchester, who's going to lead that piece of work for us from kind of a senior council perspective. But we're really hopeful that this will add loads of value to the work that we're doing, and make sure that what we do is absolutely cognizant of the issues that people face. And we'd be really happy to continue to share this work with people as it progresses. Either through social media and things like that, but we maybe want to do something like this again, further down the line. So thanks, Hazel. I'll stop there. How back to you.
Thank you. So I just want to thank everybody. I would like to thank our panel. That's Abdul, Valerie, Anushka, Safina. I'd like to thank Ed from ADASS for doing all the techie work. Thank you. I was so impressed. Thank you. I'd particularly like to thank Leah and Matt and at Northwest ADASS for really pushing this work with a real care and compassion and determination, I think. So really want to say thank you, guys. You've done a really great job there. And then finally, thank you all for attending, and I hope you found it helpful. And do get in touch with us if you think that there's anything that we could do to further support this work. So thank you, everyone, and have a good day. Okay, bye-bye.